Imagine a patient who flinches maybe even tears up when just a slight breeze hits their fingertip. Or, someone who barely bumps their hand against a doorframe, only to present in the ER with a completely shattered metacarpal.
Yeah, it's wild.
Right. That is the exact level of varied, really intense pathology you are expected to just instantly recognize when you're staring down the barrel of your plastic surgery board exams.
Absolutely.
Whether it's the FRCS or your local equivalent, you know the drill. The clinical scenarios all blur together, the statistics start to look like a random number generator, and the pressure's completely on. So our mission in this revision deep dive is pretty simple. We are going to master the high-yield facts on common tumors of the hand and upper limb.
Using a rapid-fire clinical scenario format, yeah.
Exactly. But more importantly, we want to help you understand the actual underlying mechanisms so you actually remember them when the examiner's staring you down.
We are definitely cutting through the noise today because rather than just memorizing blind lists, we're going to focus on the absolute must-know differentiators, like the structural why behind the pathology.
It's stuff that actually matters.
Right, and the classic board traps that examiners just love to deploy to see if you truly understand the anatomy.
For sure. Now, before we jump into the first question, a quick mandatory directive for you. If you really want to bulletproof your exam prep, you need to get a premium subscription to access our journal club and our clinical cases deep dives.
Highly recommend it.
Yeah, I won't spoil what's in that premium feed, but if you're serious about passing, you need it in your rotation. Also, if you learned something valuable today, just hit follow and rate the show. Okay, let's unpack this. We have a vast array of constituent tissues in the hand, right?
Mm-hmm.
Skin, fat, vascular networks, neural bundles.
Documentary variables.
Right. But realistically, we aren't dealing with a perfectly even distribution of tumors. Break down the 95% rule for us.
So it's all about playing the sheer probabilities to build your diagnostic map. I mean, the remaining 5% of hand tumors can arise from literally any tissue. Think everything from incredibly rare liposarcomas to Merkel cell tumors.
Like the zebras.
Exactly. But a massive 95% of all hand tumors fall into just 5 categories. The examiners basically call them the big 5.
Okay, hit at me.
Number 1 is ganglia. Number 2, giant cell tumors of the tendon sheath. Number 3, epidermoid inclusion cysts. Number 4, hemangiomas. And number 5 is lipomas. If you see a lump on a hand, statistically, it is almost certainly one of those 5.
Okay, so ganglia constitute a massive, 50 to 70% all those lesions, making them the undisputed heavyweights of hand pathology. We have to dissect this topic first. What exactly is a ganglion made of, and who is the classic patient walking into your clinic?
Well, the classic demographic is a patient between the ages of 20 and 40, and they are 3 times more likely to be a woman than a man. Pathologically, they're mucin-filled cysts. They're usually attached to an adjacent joint capsule, a tendon, or a tendon sheath. But, and this is key, you must articulate a crucial distinction to the examiner.
The lining, yeah.
Exactly. The cyst wall is made entirely of compressed collagen fibers. There's absolutely no epithelial or synovial lining.
Yeah, and that lack of a true lining is a vital detail because it means it's not a true cyst in the histological sense. So how do they actually form? Because I know the pathogenesis is a classic area for examiners to probe.
Oh, they love it.
Right. I read about Letterhose's 1893 theory being the most widely accepted one. This idea that ligament strain leads to fibrillation of the collagen and subsequent mucoid degeneration. But I honestly struggle to buy into that completely.
It's definitely an imperfect model. What's the main issue you see with Letterhose?
Well, I mean, think about it like a worn-out car tire. If you drive a car hard for years, the rubber gets stressed, it fibrillates, and you might get a bulge. If ligament strain in the hand is just general mechanical wear and tear, why is the degeneration so highly localized to very specific ligaments?
That's a great point.
And even more confusingly, why does it primarily affect young adults between 20 and 40? If it's a wear and tear car tire issue, wouldn't we see it peaking in 70-year-olds who have been using their hands for decades?
You'd think so, yeah.
Plus, if it's just structural degeneration, why does the fluid reaccumulate so rapidly following an aspiration?
A patched tire doesn't just spontaneously refill itself with air.
You've perfectly highlighted the limitations of the mechanical degeneration theory right there. It completely fails to explain the local epidemiology and the recurrence mechanics.
Right.
Because of those glaring gaps, you really need to demonstrate to the examiner that you are aware of the older competing theories, like Eller, in 1746, proposed they were simply herniations of joint synovium that pinch off.
And Huftman, in 1876, suggested they are embryological remnants of synovial tissue left behind in the joint capsule during development. The truth is likely a combination of these factors, but recognizing the flaws in the purely mechanical theory shows a much deeper level of pathological reasoning.
Let's map this anatomically then. Like 60 to 70% of these are dorsal wrist ganglia. Where is the exact origin point the examiner wants to hear?
The scapholinate ligament, or the SLL,
Right.
even if the ganglion presents somewhere else on the back of the hand, surgical dissection will almost always reveal a connection back to the SLL via a very tortuous winding stalk. You are essentially tracing a microscopic maze deep into the wrist joint.
So what if a patient has classic ganglion symptoms, like a
Yeah.
deep, dull ache, maybe some stiffness, but you can't actually see or feel any superficial lump?
Then you have to consider an occult SLL ganglion.
Oh, the hidden ones.
Yeah, they are tiny, completely hidden from clinical palpation, but they cause significant pain simply by exerting highly concentrated physical pressure directly on the SLL nerve endings. For these, standard X-rays won't help you at all. You need to step up your imaging to an ultrasound or an MRI to visualize that deep fluid pocket.
Okay, so if we flip the hand over, volar wrist ganglia make up about 20%. These are originating from either the radiocarpal joint or the the scaphotrapezium trapezoid joint. But the primary anatomical danger zone here is what the boards actually care about. They are intimately related to the radial artery, right?
Intimately is the perfect word for it. The stalk of a volar ganglion often winds right around the radial artery.
Which is terrifying.
It is, which means the vessel is at significant risk during a long needle aspiration and certainly during a surgical excision.
Here's where it gets really interesting, and I feel like this is a classic board trap regarding patient consent and outcomes. Say a patient sits down, they have a bothersome dorsal wrist ganglion, and they ask for surgery to cure it. What are the actual statistics we need to quote? Because the recurrence reality is pretty sobering.
It really is. Let's start with doing absolutely nothing. So, just reassurance and observation. Approximately 40% of dorsal wrist ganglia will resolve completely spontaneously over a 6-year period.
Wait, so almost half just go away on their own?
Exactly.
Okay, what if we intervene with a simple aspiration?
Aspiration has a massive 90% recurrence rate.
90%.
Yeah, and even if you subject the patient to 3 serial aspirations over time, 15% of those will still recur. Aspiration is mostly a diagnostic tool to prove to the patient that the lump is benign fluid, or just to alleviate temporary pressure.
What about adding steroids?
It's worth noting that adding a steroid injection into the mix hasn't shown clear evidence of actually lowering that recurrence rate either.
So the patient demands we cut it out, we mobilize the stalk, incise the capsule, and tangentially excise the ganglion right off the scapholinate ligament.
Even with meticulous surgical technique, you still have up to a 40% recurrence rate reported for dorsal ganglia.
That's wild.
And for volar ganglia, it's between 16 and 42%.
So statistically, surgery offers absolutely no proven long-term advantage over observation alone in terms of resolving pain, stiffness, or weakness. That kind of implies that an underlying joint disorder or instability is responsible for both the ganglion's formation and the patient's symptoms. The ganglion is literally just the messenger.
Exactly. You are treating the symptom, not the underlying mechanical instability.
Let's pivot to the smaller players in the ganglion family really quick.
Yeah.
We have the flexor sheath ganglion, accounting for about 10%. These arise right from the A1 pulley at the proximal digital crease.
Right.
Because they are anchored to the pulley, they present as firm, tender masses that crucially do not move with the flexor tendon when the patient bends their finger. Treatment starts with needle rupture and steroid, and if that fails, we do an extensile exposure and excise the ganglion along with a small cuff of the underlying A1 pulley to prevent recurrence.
That's exactly right. And moving distally, we have mucocysts. These are simply ganglia of the distal interphalangeal joint, the DIPJ. You'll see these in older patients, typically in their 5th to 7th decades.
The classic visual presentation here is nail grooving, right? The mechanism is so fascinating to me. The cyst expands and puts direct, sustained physical pressure on the germinal matrix.
Yep, it crushes it.
The nail grows out with a longitudinal groove because the cyst is literally denting the cellular factory where the nail plate is manufactured. You'll often see this alongside Heberden's nodes and radiological evidence of severe DIPJ osteoarthritis.
When you are operating on a mucocyst, you usually make a curved or L-shaped incision to trace the cyst proximally, but the absolute non-negotiables you must state in an exam are You must meticulously preserve the delicate extensor tendon insertion and avoid damaging that germinal matrix further.
Crucial.
Extremely. Crucially, you have to debride the underlying osteophytes, the bone spurs, at the exact same time. If you leave the rough bone spur that caused the capsular irritation, the cyst will just come back.
And what if the joint is completely shot?
In cases of severe osteoarthritis, you might bypass excision entirely and just consider a primary arthrodesis to fuse the joint.
Makes sense. Let's round out the non-ganglion lumps quickly. How do we distinguish a dorsal ganglion from a carpometacarpal boss?
Well, a CMC boss is an osteoarthritic spur over the dorsum of the second or third CMC joint. Unlike a ganglion, which has some give to it, a boss is rock hard and completely immobile because it is literally bone.
Right.
Just be aware, though, the friction from the boss can sometimes create a small secondary ganglion directly over it. Treatment is excision of both the fluid pocket and the bony osteophyte.
Got it. And what about the extensor digitorum brevis manus?
That is an anomalous accessory muscle belly. It swells when the patient extends their fingers, causing an aching pain that mimics a dorsal wrist ganglion. But tissue consistency on palpation and an ultrasound will clearly show striated muscle, not a fluid cyst.
Perfect. Okay, we've covered the fluid-filled cysts. Let's move to solid masses. I'm going to give you a clinical scenario.
Let's hear it.
You examine a mass on a patient's finger. It's firm. You shine a pen light on it, and it does not transilluminate, ruling out a simple ganglion. Furthermore, it is completely 100% painless. What is the second most common soft tissue tumor we must immediately suspect?
A painless, solid mass in the digit is a giant cell tumor of the tendon sheath until proven otherwise.
Yep. In the operating room, the classic board description is a yellow-brown, multiloculated mass. But why is it yellow-brown? This is the kind of mechanism that makes the facts stick, I think.
Exactly, the why.
It's because the tumor is packed with lipid-laden macrophages, giving it the yellow tint, combined with heavy hemosiderin deposits from chronic microbleeding within the tissue, which adds the brown. Also, what's the other name for it, and what's the anatomical trick examiners use?
Right, so it's technically known as pigmented villonodular tenosynovitis, or PVNS. And the anatomical trick is that despite the name tumor of the tendon sheath, it is actually not always physically associated with a tendon sheath.
Such a classic trap. So, it's a benign tumor. Benign usually means harmless, so we just pop it out through a marginal excision, right?
Be very careful there. Benign does not mean harmless in this context. You have to respect it because it is highly locally invasive. It will literally wrap around neurovascular bundles and infiltrate local tissues.
So it's a messy excision.
Very. You perform a marginal excision, but you must counsel the patient and explicitly tell your examiner that because of this invasive growth pattern, there is a 30% recurrence rate. Furthermore, while malignant transformation of a standard giant cell tumor hasn't been definitively proven, you must be aware that a primary malignant variant of this specific tumor does exist.
Good to keep in mind. Let's contrast that painless mass with the breeze-sensitive fingertip we mentioned at the start of the show. A patient comes in with a lesion so exquisitely painful, they physically recoil when you bring a pen light near their nail bed.
Now we are firmly in the territory of the glomus tumor.
The pathology here is incredibly specific. A normal glomus body is a tiny arteriovenous anastomosis, essentially a microscopic shunt between an artery and a vein that serves as a thermoregulatory valve. You find dense clusters of them in the reticular dermis beneath the nails.
Exactly.
So a glomus tumor is basically a benign vascular hematoma where that thermostat structure just grows completely out of control.
And because it's a broken thermostat, the clinical presentation is an unmissable triad. Examiners want to hear this. Number 1, paroxysmal pain. Number 2, pinpoint tenderness. And number 3, cold hypersensitivity.
The cold hypersensitivity makes perfect sense mechanically. The tumor is a chaotic bundle of thermoregulatory vessels, so when the ambient temperature drops, the tissue reacts violently and painfully.
Yeah.
Visually, they look like small hemangiomas with a faint blue discoloration under the nail plate, often causing ridging. But the clinical examination is where the eponyms really come out.
Oh, examiners love their eponyms. They want to hear 2 specific signs. First is love sign. This is where you take a pinhead or a paper clip and palpate the nail bed until you find one exquisitely, wildly painful spot.
Ouch.
Yeah. And the second is Hildreth's sign. You exsanguinate the affected finger and apply a tourniquet. When you repeat the pinhead test, the pain is dramatically reduced or entirely absent.
Hildreth's sign is just pure physics. By applying the tourniquet, you are cutting off the arterial blood supply and deflating the vascular pressure inside the tumor capsule. Without that engorged pressure physically crushing the surrounding microscopic nerve endings, the pain just vanishes.
Exactly right.
Treatment is meticulous surgical excision.
But what if the patient comes back 3 months later complaining of the exact same agonizing pain?
It almost certainly indicates that there were multiple glomus lesions and you missed one. You have to go back, utilize high-resolution MRI if needed, and explore further. Okay, we've talked about tumors that originate in the soft tissues in the vascular bed. But what happens when the very scaffolding of the hand, the bone itself, starts betraying you? Let's say a patient barely bumps a door frame and presents with a pathological fracture of a proximal phalanx.
Your primary suspect has to be an enchondroma. It is by far the most common primary bone tumor of the hand.
Biologically, this is a slow-growing, benign area of abnormal hyaline cartilage formation that decides to grow right inside the medullary canal of tubular bones, like the phalanges or metacarpals. When you order an X-ray, the examiner is waiting for a very specific read.
Right. You are looking for a central radiolucent area, like a dark cavern inside the bone, featuring speckled calcification. Think of it like coarse grains of salt scattered inside a hollowed-out tunnel.
Great visual.
Thanks. And because this cartilage mass is expanding outward from the inside, you will see a distinct thinning and ballooning expansion of the surrounding bony cortex, which is exactly why it fractures so easily.
Treatment is typically curettage to scrape out the cartilage, and you can either pack the defect with bone graft or leave it to heal. But let's elevate this, because the examiner will inevitably push you on syndromic association.
They always do.
If I'm sitting in the exam room under the glare of the lights, I'm going to mix up Olier's disease and Maffucci's syndrome. Give me the simplest heuristic to keep them straight.
Okay, here is how you separate them. Both involve multiple enchondromas scattered throughout the skeleton. Olier's disease is just the enchondromatosis, but these lesions tend to be massive, causing severe skeletal deformity and bowing of the bones.
Okay, just the bones.
Right. But the critical danger with Olier's is that these large lesions have a high risk of differentiating into malignant chondrosarcomas. Any sudden change in pain or size warrants an immediate biopsy.
Got it. And Maffucci's.
Maffucci syndrome is the multiple enchondromas plus an associated systemic finding, specifically soft tissue vascular anomalies like hemangiomas or lymphangiomas. If you see the bone lesions plus vascular malformations on the skin, it is definitively Maffucci's.
Brilliant. Let's fire through the remaining bony lesions to make sure our differential is bulletproof. Osteochondroma.
Unlike the enchondroma, which grows inside the bone, an osteochondroma is a benign osseous spur that grows outward from the bone surface, but it is defined by having a distinct hyaline cartilage cap.
And do they turn malignant?
The risk of malignant transformation of these in the hand is incredibly low. We really only operate on them if their physical bulk causes an angular growth disturbance in a pediatric patient or restricts tendon glide.
Next is the osteoid osteoma. This one hits patients in their second or third decades and has a hallmark symptom, a constant, severe, dull ache that is specifically, almost magically relieved by NSAIDs.
Yes.
The mechanism here is brilliant. The core of the tumor, called the nidus, secretes massive amounts of prostaglandins which cause intense pain and local inflammation. NSAIDs chemically block prostaglandin synthesis, effectively turning off the pain at the source.
The diagnosis can be tricky, though, because the X-ray changes are subtle. The entire lesion is usually tiny, like less than 1 centimeter in diameter. You are looking for that small central sclerotic nidus, the prostaglandin factory, surrounded by a dark lucent halo, which is in turn surrounded by a thick rim of dense, reactive sclerotic bone.
So it looks like a bullseye.
Yeah, it looks like a tiny eye of a storm surrounded by a hurricane of dense white bone.
Great analogy. Finally, let's contrast the bone cysts. Simple versus aneurysmal.
Simple or unicameral bone cysts are essentially just fluid-filled cavities in the bone. They're actually quite rare in the hand. You'll see them much more frequently in the proximal humerus. If you do encounter one in metacarpal, you can treat it with aspiration and a steroid injection or curettage.
But an aneurysmal bone cyst is a completely different beast, right? And the name tells you exactly how it behaves.
Precisely. Occurring mostly in the second and third decades, they are technically benign, but they are incredibly aggressive. They are blood-filled, multiloculated cavities that expand and blow out the surrounding bone cortex just like a vascular aneurysm blows out an artery wall.
So they just destroy the local area.
They invade locally and are highly prone to local recurrence. Standard curettage isn't enough. You need to aggressively augment the scraping with cryosurgery like liquid nitrogen to kill the microscopic peripheral cells.
And if it's too big?
If the lesion is particularly large or destructive, You bypass curettage entirely and go straight for a wide en-bloc excision to minimize that high recurrence risk.
That structural, definitive decision-making is exactly what separates a passing candidate from a failing one. We've covered a tremendous amount of ground today, navigating from the sheer statistical probability of the Big Five down to the prostaglandin mechanics of an osteoid osteoma.
It really highlights how crucial it is to look beyond the superficial lump. You have to understand the underlying tissue mechanics, the fluid dynamics, and the statistical behaviors of the pathology.
Absolutely. To wrap up, I want to leave you with a final, high-level clinical thought to mull over as you study tonight. We talked extensively about glomus tumors being exquisitely painful vascular hamartomas of the body's thermoregulatory system. Consider how the embryological origins of the hand's vascular network might explain why these thermoregulatory tumors are so fiercely concentrated in the subungual space, right under the fingernails, far more than anywhere else in the human body.
That's a great puzzle.
Right. What is it about the specific embryological development of that distal capillary bed that makes it such a hotbed for this specific structural anomaly?
That is a phenomenal question to drive some late-night anatomical reading, and it's exactly the kind of deep-level synthesis examiners respect.
Exactly. If there was a specific pathology we covered today that you want clarified, or if you have a theory on that embryological glomus question, just drop a comment or question below. Active recall, questioning the mechanics and forcing yourself to explain the why are the absolute keys to passing the FRCS. You are building a diagnostic map. And while it might feel murky at times, the anatomical patterns are there if you know what to look for. Keep studying the 95%, don't get distracted by the 5%, and we'll see you on the next revision deep dive.